So we are a value-based care, and we take care of our seniors, 55 and up. Of course, if there's a family member who wants to be there and if under 55, absolutely, we would love to take care of those patients. Our mission and vision and also our values, we care for our seniors. We want to make sure none of our seniors are uncared or left behind. So we love taking care of our patients by providing preventive care. We've got a lot of stuff during the first clinic visit where we have about 90 minutes. That's never heard of. I used to work at different places in Alabama, Washington State, and at the most I would see a new patient for 40 minutes. I was thinking 40 minutes. That's by the time you're enrolling the patient, you don't get much to talk with your patients and know what's going on. So here at Sage Hill, we have that 90-minute talk during the first visit where we not only talk about the patient's chronic diseases, can I get to know the entirety of the patient's, medical history, showing history, that kind of stuff. We also have so many things in order to rule out. Some patients don't even know they had COPD. Some patients don't even know they had some heart disease. We do the echoes, spirometric tests. So it's each and every patient is kind of tailored to have their own, script kind of thing. This is what it is. We work with. We have providers across 3 clinics. One in I'm going to share that information. Also, we have the booth down there we want to talk about. So I want to start the presentation, and we can always have this question and answer sort of thing at the end of the presentation. I can talk more about the Sage Hill at that point too, and also discuss our presentation today. Okay. So, identifying the possible mediator in effective chronic disease management. Our objectives for the day would be, we need to understand the burden of caregivers in patients, with Alzheimer's disease. And it's important how the caregivers, and also important for the patients overall, their health, especially when you're taking care of, Alzheimer's disease. Explore chronic disease management, the challenges in this particular population, but also overall, if you look at the broad spectrum, we want to have, the entire chronic disease management for the caregiver itself, as well as the patient that they're taking care of. The concept of mediator is going to be something new you may have heard of. Strategies for supporting caregivers. Now, Alzheimer's disease impacts not only the patient but also the caregivers, right? It is important when you take care of your patients, right, with Alzheimer's, there are lots of challenges. It could be overwhelming for the caregiver itself, and how much of support we can provide, right? So their, emotional, physical needs and everything matters a lot if you want to, take care of their loved ones with Alzheimer's in particular, right? Chronic disease management can be enhanced by supporting caregivers, exploring potential mediators to improve outcomes. Now, the role of caregivers in Alzheimer's disease, right? Like we said, emotional, physical, and logistical responsibilities, right? Common caregivers demographic. I do have a picture here, the infographic about a caregiver. You want to have your time off, from all the stress, you take care of those patients, right? I have meditation, yoga, or just a me time, go meet a friend, have lunch with them, CDM, which is nothing but the chronic disease management. I just want to pause here for a minute and say, chronic disease management, it's like, epidemic, right? For example, let's say in the state of Arkansas alone, for diabetes, we spend close to $4 billion, and that includes, the medications per person, which is about 15,000 to 20,000, transportation, food, water, right? Now, we need to take care of those. For example, diabetes alone, right? If you don't take care of your diabetes, you can have, they could be underlying reasons. They could have some depression, anxiety, a lot of things. As a primary care physician, for me, it will be more important to lessen this diabetes. And also, if they're having a chronic disease like hypertension, right? So our goal is to improve the quality of life, reduce ER hospitalizations. That's important. Also involves lifestyle changes, medication adherence and monitoring, right? If you're diabetic, you want to make sure you get your insulin shot or any oral medication. You want to make sure you're eating healthy. Lifestyle changes, have a good night's sleep, avoid this tobacco, alcohol, any of that stuff, right? And that also involves exercise, diet, a lot of things goes into it, right? But it's a marathon, it's not going to happen overnight, and you need a provider or a primary care physician who works hand in hand, right? The role of caregivers, obviously it's more like emotional and physical support for sure. They often manage medications, appointments, activities of daily living, right? Caregiver stress can negatively impact the patient's outcome, right? Absolutely. Now, if you are stressful and you're taking care of this loved one who's dealing with Alzheimer's disease, it's not easy. And as you know, Alzheimer's alone as a disease does not just affect the disease itself, but it does also affect the memory, right? 30 to 50% of population with Alzheimer's disease have neurocognitive symptoms like agitation. Imagine you're dealing with that. Now that could be, physical outburst or verbal outburst, right? So how do we deal? There's a lot of things going on back of the mind as a caregiver, right? So you've got to manage that stressful levels, use resources you have to take care of, right? Taking that patient, their loved one, to the psychiatrist or maybe a neurologist, optimizing the medication, right? So a lot of things goes in it, and 30 to 50% of these patients have neurocognitive disease, those symptoms like agitation. The mediator cause, it explains the mechanism by which it occurs, right? In this context, as Alzheimer's disease and caregivers, right, developing a mediator of chronic disease management, right? Imagine you have a patient like with diabetes. Are you taking the insulin? Are you eating healthy, right? If you take care of yourself, well, then you can provide that care for your loved one. So the more you manage yourself, the better the patient can be managed. The potential mediators identified would be caregiver self-efficacy. Now that could be with just having that self-efficacy, having that me time, the meditation or something having, something away from, where they can have time spent with the family, other people, a friend, or meeting. Little things goes a long way, eating healthy diet, or maybe going for an exercise, swim, Health literacy is important because you need to understand the disease progression, right? I can give an example. I had, during my second year of my med school, I happened to meet a family, both husband and wife, where they were very educated people. Wife happened to have symptoms, very early onset of Alzheimer's, right? And she's become more forgetful, she was out of it, no risk factors whatsoever, no history of stroke or any family history of Alzheimer's, right? And as the disease progressed, right, she had manifested many things, symptoms-wise, depression, anxiety, agitation, right? Forgetfulness was awful. She could not even, at some point, she had an 18-year-old daughter, she was not able to recognize. There was days, good days and bad days, right? So that's how I was there at a psychiatrist's place where she was referred by her PCP to manage those symptoms. And it's been about 20 years, I think. I happened to meet the psychiatrist, my attending, in 2020, and I kind of asked what was going on, because that looked very, one of those, cases I would say in my life encountered. She did not make the pandemic, she died. She died because of other complications. The husband, who was primarily the breadwinner and also a primary caretaker, was dealing with depression and anxiety. However, their 18-year-old daughter happened to be a neurology resident in Houston, and I'm sure she probably would have done lots of research in dementia. So that's what it is, So it takes a lot, taking care of patients with Alzheimer's.
But at the same time, if you have that enough support, things can be managed. There'll be some days. Emotional well-being is definitely something very much important. Um, it is said that approximately 12 to 13% in the United States, sometime in their lifetime, have depression. Now, when you combine with that depression with chronic diseases like diabetes, asthma, cancer, hypertension, right? Now, that's a bidirectional effect, meaning if the depression is not taken care of, how are we going to take care of the other things, right? They may miss taking the insulin or other medications for blood pressure, right? That's very important, as a family physician for me to understand what are the other things too. There are other tests we do in our clinics to talk about the, screening for depression, anxiety, dementia, a lot of things, right? So we need to understand that, when we take care of our patients, we also rule out other things which is masked by, depression, right? So it's important, not necessarily you can start somebody on antidepressants right off the bat, right? A lot of things goes. It could be an acute stressor, somebody who lost a loved one, a lot of things. Medication is not the only one to get started with, right? And then, we need to have our own self-coping mechanisms, deep breathing techniques, relaxation techniques, now, what are the strategies to strengthen mediators, right? Education and training programs, and I'm sure Alzheimer's cancer has a lot of resources. Like I see a lot of vendors here, right? They have that support system, right? Having that peer support group too, definitely, families, friends, Mindfulness and stress reduction techniques is one of the strategies, and also this is very much important, role of interdisciplinary. You are not all alone, right? You gotta have your doctors, you gotta have your care team, your chronic disease manager or case manager who works with you, right? Everybody is in it, right? We're as a team. And when you have that association, it's good for the patient and also the caregivers. Research out there says that the more frequent you see your physician, the more better you're healthier and happier. Now, there has been some evidence-based insights. Those are the interventions we have for the support caregivers, which can improve the chronic disease management, caregiver training, respite services, and support groups. Now, I see there was a respite support group here. Some patients probably need, just a day-long sort of thing, or have somebody come over for part-time, maybe a long-term care or a short-term care, a nursing home, right? So you need to make use of the support system. REACH 2, which is the reducing environmental and caregiver stress in healthcare. Now this is very important when it comes to the caregiver. It reduces the caregiver burden, depressive symptoms, and self-care. The other one I was going to talk about, the Enable 2. It's for patients who have been in cancer, right? And it's as a family, you're dealing with cancer, and as a caregiver, you have multiple visits to your doctors, right? And this is the group which helps with reducing that burden of symptoms and giving that extra quality of life, right? When it comes to a stage where you decide as a family, hey, this is about time. We got to have palliative care, which can help reduce the overall quality of life and also the burden on the our caregivers. And then the other one is the New York University Caregiver Intervention that also reduced nursing home placement rates and increased caregiver feelings of efficacy and social support. So there are support groups out there. It's all about you seek help. Now, one of the case studies was a support group for caregivers led to increased medication adherence. Definitely, you're healthy, you take care of your loved ones, medication adherence improves, right? Particularly when we're talking about the Alzheimer's disease, we are delaying the progression of the disease, right? So it's not like you're gonna reverse it. It's decrease the progression. Right? And it also showed that there were lesser ER visits, Health literacy as the mediating role of caregiver education, because you need to understand the disease process, right? So until unless you know what's going on, what the expectations are, what's the help you have, you know. So these are the ones, somebody who attends something like this or bookshops, learn about your family members' health. It's always helpful, you know. Now, as a provider, what we do for us, for not only the patients but also the caregivers, we screen and support caregivers, right? Now, for example, at Sage Health, we do have, seniors is what we see, right? Geriatric population, right? Not only we see the chronic diseases, but also mild cognitive or, moderate to severe cognitive patients too, right? So we plug in those gaps, and it's the beauty about us is we don't let our patients come back in 3 months. It's more frequent visit. Every time the patient leaves the clinic, they know they love to come back. We treat them as a family because we have so many activities like, bingo, something which can, make those, activate your memory sort of thing. We have sneakers, silver sneakers, which is more like an exercise sort of thing, A lot of activities we have, and then we recommend that, And for community build caregivers friendly systems, and we also for the caregivers prioritize their own health. Our recommendations would be having that care planning. Everybody, provide specific resources and training, regularly assess caregivers' well-being. Overall, end of the day, it's the caregivers. We need to understand that they go through a lot of challenges and stress taking care of their loved ones with chronic diseases or anything like dementia, right? Supporting caregivers can be with the key mediators like self-reliance, having those mediators. Now, final takeaway would be supporting caregivers is supporting patients. That's something I strongly believe. End of the day, like I said, we need those caregivers to be healthier, need to take care of their own health, and also, once they do that, it automatically improves the loved ones with the chronic diseases. I'll leave that here, and then I'll take some questions. I do have all the information for our 3 clinics in North Little Rock, and Bryant. We have Clinton, who's our area manager with the board there. We can just go and talk more information. If you need to, I'll be here around for some time. But I'll take some questions. Go for it. Yes, sir.
I was a little confused about what exactly the mediator is. Is the mediator the caregiver, or is it the relationship between caregiver and doctor?
So mediator could be for the caregiver, right? When you are taking care of, as a caregiver, right, you want to take care of your loved ones, and you have that self-reliance, health literacy, you understand. And it's more like a collaborative care, I would say, for the caregiver too, not only with the loved one they're taking care of, but also their own health, in a way. Yes, ma'am.
What insurances do you all accept? What insurances do you all accept?
Yeah, absolutely. We got Clinton, he's the area manager, so he can talk about the benefits, insurance. I can talk about the medical stuff.
Absolutely. So insurance we accept Aetna, Allwell, Cigna, Humana, WellCare, and we also accept traditional Medicare. So all Medicare supplements, we accept those as well. Now United Healthcare is right now, and we're working to get Blue Cross Blue Shield hopefully by the end of the year.
Needed him to repeat the insurance.
Insurance, I talk loud, so I don't need the microphone. Insurance are Aetna, Allwell, Cigna, Humana, Devoted, and traditional Medicare, and WellCare.
Thank you.
Any other questions? Here in the back.
We We have Blue Cross and Blue Shield, and I know y'all said at the end of the year, what will that mean?
So by AEP, you'll be able to enroll and become a patient with us for if you have Blue Cross Blue Shield. Yes, ma'am.
Do you accept Medicaid?
No Medicaid. No Medicaid. But all Medicare.
Are you an Arkansas practice or multi-state?
Yeah, we are in multiple states like Maryland, Alabama, Gulf Coast, Mississippi, and in Arkansas. We are expanding. Yeah.
Do you work with the VA?
So as far as insurances, so we do have several patients that are veterans right now, and if they do have the Medicare Advantage plan or traditional Medicare, as long as Medicare is primary, then we do still accept those patients. We have several patients that are veterans, and it does not affect their veterans benefits at all.
Any other questions?
Go ahead. No, go ahead.
Okay. If you already recently established care with a PCP who's not necessarily specialized in this, can you transfer over to y'all?
I think so, yeah. If everything goes well, yeah, we do have some patients, come over, we take care of it. But if they do have like a specialist already they've been seeing, we would love to keep those specialists because we have quite a few specialists in our network. And yeah, absolutely. And we have about 5 providers, including me and a nurse practitioner. So, like I said, we want our patients more frequently. We want to see them. And the cadence for visits, it's not like a traditional where fee-for-service, you come in 3 months and we believe in having that patients more frequently. And when that happens, we reduce that ER visits or hospitalizations. Patients are happier, healthier. So it's more like, it's a holistic approach of taking those geriatric patients. And when I was working here in different states, and when we first moved from Washington State, I was with UMS. I loved it. It's just that the fact that I had like over 1,000 patients. However, the time I spent with those patients was so little. Sometimes I was thinking like, how am I going to address so many things? And because a lot of elderly folks, it's hard for their transportation. It's been one of those co-pays, right? And I believe in patient education, right? When you believe that, you educate your patients what they're going through, right? And then it makes a huge difference. It makes a huge difference in their life, day-to-day life, right? And sometimes I feel it's been about a year and a half with Sage Health. I feel blessed. I had, sometimes, God kind of tells you, this is it. I had a calling for geriatrics, and it worked well for me. As a family physician, I used to see anybody from womb to tomb, and so it was like at this point I'm so happy. I learn a lot from my patients, right? My dad was a family doctor in Canada and in India, and he used to always tell me that it's a learning experience. It's like a lifelong learning. As a physician, and I learned a lot. Every patient is different, and their background is different, their medical conditions are different, right? But as long you have that connection, you build that trust, that rapport, it can go a long way. It's not only knowing your patient's diagnosis, but knowing them as a whole. It's a different level, and also the research says that too, right? The more frequent visits with your PCP, right? They tend to be healthier, and we have providers after hours too. Over the weekends, like 365 days, 24/7, there's a provider after hours. So, sometimes I tell my patients, if you have something like a stroke-like symptoms, then come in the ER. Otherwise, you can always call us anytime. And we make those decisions, and patients are happy. They don't want to stay in the ER for such a long time, right? It goes really well.
Are you still practicing with UAMS, and how do you coordinate with them with patients or not?
So right now I am with Sage Health. I used to be with UMS a year and a half ago, but we do have some specialists at UMS. So for suppose a patient with dialysis, right, the nephrologist is at UMS. So we make sure we have those relationships with other healthcare systems like Baptist and UMS. And unless the patient's like, hey, you know what, I want to see another doctor, is that okay? Absolutely, we do that. But we tend to keep those patients because sometimes they're in the process of chemotherapy, right? You don't want to move them around to a different place. So unless they want very specifically, yes, we have lots of healthcare systems we collaborate with. So and as long as they're in our network, we make sure they get their help. And the thing is that we also have something called like a Rubicon MD, where there are hundreds of board certified specialists. We just message them via email about our patient, and we get the test. We get the answer right away within an hour or two, maybe 24 hours. While we're waiting for the in-person visit with the specialist. So we make use of every opportunity, every resource we have. And some patients say, like, I've been going to an endocrinologist for my diabetes. As a primary care doctor, I take care of my patients with diabetes, right? If it's anything beyond my scope of specialization, we know when to refer those patients, especially if it's like a new onset or something like a new diagnosis of cancer, that's beyond my scope. So we make those decisions. And we talk about our patients on a regular basis, who needs what resources we get, and we connect those gaps if they need.
Someone did ask about the hours. I think the microphone's back there. Someone did ask about the hours. So our clinics are open Monday through Friday, 8 to 5. But like Dr. Kotapati said, we do have a physician on call 24/7. So if there's anything that happens that they do need care, you can call the nurse at the triage line, and we'll definitely see you. And something else that we do, we also coordinate with your insurance to provide transportation to and from the doctor's appointments and to those specialist appointments. So I know that's important to a lot of people as well.
What's the mileage that you all do?
So most insurance, because we do coordinate with the plans, some plans do up to 100 miles one way. So yeah. Yeah.
Understood. Understood that you said yes to you guys being a part of a multi-state provider, that you're a multi-state provider. Does each SAGE office in each state operate independently, or is there a centralized database so if a patient who's in the SAGE network in Little Rock comes and they vacation in another city, they're able to go there and the provider will already see them as an established patient?
That's a great question. If you happen to visit Alabama, we have about 5 or 6 clinics. And we use one EMR, electronic medical records. We share records within our network, and it's easy that way. They know what's happening. The good thing about it is, they pick up the phone. The provider down in Alabama calls me or the provider and tell, hey, your patient was visiting here. So we have that collaboration, and they share all the information. So next day when I show up at work, I know my patient was evaluated by this doctor in Alabama. So we have that. And also we have a good thing called ER Share, Arkansas Share, where other healthcare systems, let's say one of my patients goes to Texarkana and he happens to be admitted in one of those hospitals, right? If it's within our network, we make sure it comes to us directly. And when I see the notes from the Texarkana, I'll be like, wait a minute, I just saw this patient and he's admitted in Texarkana. What's going on, right? So I read about what happened, and that kind of stuff. So we make sure we reach out to our patients and their family, and once they're discharged, or maybe like if they're being urgent care, we'll make sure we get them in with us, and talk about it and see. So majority of them are within network. They are adding more healthcare systems in Arkansas. So Epic is one of those EMRs. UMS has the chair. Baptist does it. And I believe St. Vincent at some point is going to move to Epic later this year. So we get those records and we request. We have care teams, right? Every provider has their own medical assistant. It's a team. And we know our patients in and out and say like, hey, this patient was admitted to find out, right? So we have case nurse manager, right? That's what happens in the fee-for-service place where it happens in our clinics where we have a good care system to follow up on our patients.
There's a question. And if you have any, I'm going to put Dr. K on the spot. I know you talked about how well you guys are going to take care of yourselves. Do you have any dementia or Alzheimer's questions from your hearing? A lot of people will sometimes have those, but if you have one, please raise your hand.
Yes, ma'am.
So she would like to know, do you do the Alzheimer's testing or, the blood test? Do you do that at your facility or do you have a capability?
So it's a new test. Sometimes the insurance will be okay, but we do like a preliminary test where we do the MMSD, which is the mini mental status, right? We do slums, we also do mini-COG. If everything goes well, we don't want to label our patients with dementia. We want to rule out the older ones, the traditional organic ways where, if the patient has had a history of something like a stroke or a traumatic brain injury, right? Maybe that was the reason why, he has a decline in his cognitive functions, right? We want to rule out, thyroid abnormalities can be one of those, depression can mask, we call it pseudo-dementia, right? So we want to rule out, unless and until we know this is what seems to be going on, we make those, we can do like a CT scan, MRIs, blood tests, and, coordinate our care with neurologists, and we do the next steps. But yeah.
Okay, I have another question. How does caffeine affect a person with Alzheimer's and dementia?
So caffeine is more like a stimulant, right? I mean, I love caffeine. When I was a medical student, I used to, just chuck in 2 marks of it just to keep it, throughout my day. But sometimes, overdoing it can cause some irritability, agitation, or maybe it's a diuretic, right? Especially if the patient is on a medication which is already on a diuretic, right? You don't want to be dehydrated, right? It can mess up with sleep. That's important. And I always tell my patients, hey, if you really want to drink caffeine or caffeinated beverages, do it before 11 o'clock, Obviously, you don't want to go overboard with 3 or more cups. So it's tough to assess that. But then again, I would just rule out if there's anything going on with any vitamins or anything which is people can have different food habits changed and the taste. You probably heard about the COVID symptoms. Initially they said oh, I can't, and so it can happen. So it takes some time to retrain the mind. It's more like a behavioral sort of thing, but obviously not with caffeine. It's okay.
Okay, so she would like to know about how to manage hallucinations with Parkinson's.
Hallucination. Yeah. Yeah, that's a very good question. Like I said, 30 to 50% happens, with Alzheimer's disease, with agitation that can lead to and Parkinson's is different ball game too, right? Hallucinations, you want to rule out the least causing ones. Now remember, they may not be peeing properly. That could lead to a urinary tract infection, right? When that happens, it can cause altered mental status, right? Delirium, we may call it, right? So unless that is not ruled out first, then we don't want to jump into medications like an antipsychotic or something, right? And I've seen patients in the past when I was doing hospital medicine, where patient gets admitted and it's an entirely different room for them, right? It's a different setting. They're not used to it, right? They can feel confused, disoriented, right? But sometimes we want to rule out that UTI. That's probably the reason why. Once you treat them, we try to make sure the caregiver is with them for a few hours. But if all of this is ruled out and if the patient is still hallucinating, then I strongly suggest medications. Again, always want to have that collaborative care. It could be like a psychiatrist, it could be a neurologist, and starting off something. If you want to assess everything before starting them on some antipsychotics or anything like that.
Thank you. So Mr. Bill would like to know, does your services include palliative care or do you work with palliative care services?
Yeah, great question. I like that. So we do have some patients, and we work with a group here who's part of our network. When obviously it has to be a talk with the provider and the family members because it's a collaborative. Everybody is in it, right? We have our own behavioral therapist, like a social worker too, right? So we involve everything. And once the decision is made, if it's a palliative, then we have a group who works with us.
Okay, I have another question. And there's a palliative care provider, I told you, so if anybody's looking for palliative care, we can hear later. So, I have a question about the new drug treatments. They're still kind of in trial with the new drug infusions for Alzheimer's. Could you talk about that a little bit?
I don't want to give any misinformation or anything like that. That's beyond my scope. But any drug in trial, it's going to do the basic thing is the progression. It's going to delay the disease progression. We have memantine, donepezil, which has been there for years. That works. Again, it can prevent and delay the disease progression in terms of the memory and all that stuff. But they are experimental drugs, and believe it or not, we spend $360 million a year for dementia. So there's a lot of research in it. So always there'll be new medications which can help improve the quality of life for that patient as well as the family members taking care of that patient.
Can I ask you that?
Yes,
So,
ma'am.
one of the qualifiers for the medication in the future is you have to be in early stages. If you are in late stages, middle stages, you usually do not qualify. You have to be almost in the mild cognitive stage to qualify. So, okay, I have two more questions.
Yeah. So
So is it possible for the Alzheimer's drug to stop working? She was on Griseltin and Memantine. So is it possible for the Alzheimer's drug to stop working?
like I said, these medications, it's not going to do reversible, but at least it will delay the disease progression, right? Depending on the the damage it has happened, like regular CT scans, those are the things which will give us an idea. But medications, especially for Alzheimer's, it's basically you're delaying the process of the disease progression. Now, sometimes adding another drug with it can enhance that, change. But again, I don't want to give that information, But sometimes adding too many, and I've seen patients on MNT and donepezil, right? So it should, to some extent, again, it depends on that, how far the disease progressed and what the benefits, right? So it's just like you got to know your patients and see what it is, right? Again, we want to still rule out the other stuff to even thinking about starting them on medication too.
Okay, I have another question. This lovely lady here, her husband is 89 years old, received a diagnosis of Alzheimer's about a year ago. And I guess her question is, what kind of treatment or how can she make his quality of life better?
Yeah, that's great. Now, the decline of memory may have started something, and it's more noticeable now, right? Now, sometimes, it's just the physiological changes, right? It could be like stresses, or maybe a lot of things going on too, right? Now, if it's been diagnosed as Alzheimer's, right? I'm sure your primary care doctor would have already started on medications, right? At least. But definitely, we don't know how long will that work or how long it's been. I can't really say that. But if it's been diagnosed as Alzheimer's disease, then I'm sure they've probably started on some medications like donepezil or Lamantine. But again, it's all about making comfortable for the patient environment at home, right? That'll, you want to have that surroundings and, that it makes it a huge difference for them,
Okay, this is a question. Can you hear me?
Yes.
So, she wants to know what exactly is Alzheimer's.
Yeah, is it
Is it
a disease that's actually like eating the brain tissue? What is it exactly?
so she wants to know what is Alzheimer's exactly.
So yeah, it's a neurodegenerative, it's just like degenerating your white matter, right? The memory areas, like amygdala or, So it could be with multiple reasons, like, somebody who had a stroke could be having a risk factor for that memory changes, right? Now some people may have like regeneration of those cells, damaged cells, but some of them, it takes longer, and over the time, if they have other risk factors like smoking, cigarettes, or substance abuse, anything like that, that could be contributing to it. But yeah, family history definitely contributes there. Somebody like grandfather or father or somebody, not necessarily same immediate family, but it is a risk factor. And it's a neurodegenerative, so there is a degeneration in the memory centers and learning centers, right? They tend to lose their cognitive function, and you see that decline, At some point, they tend to lose their active daily living activities, like, bathing, combing, grooming, So it's a decline, it's a process, slowly that you see that cognitive functions decline over the time. And it could be with multiple things too, like, nutrition, somebody, is deficient with vitamin B12 or something like that, or thyroid, I don't know what it is too. So you want to have that checkup and this, but to say it is a neurodegenerative disease.
I have a medication question over here.
Yeah.
Okay, so this is Mr. John.
Hello? Yeah, there we go. My wife is taking right now Lentidine, I believe it is, and you go to the next stage on drugs for treatment, and it's Domentazole or whatever, and there's another one that starts with a C, I can't remember. And I don't know if you know the drugs I'm talking about. And it's the next stage up as severe Alzheimer's progresses when you're roughly stage 6 or so. And the problem
side effects profile, yeah. Yeah.
Side effects basically indicate that it's normal, not occasional. Normal to be nauseated for 2 to 3 weeks. Okay, so she throws up 15 minutes after taking the drug. She can't hold down anything, water, nothing for 24 hours until she blow up. And I give her, it's a drug for nausea.
Yeah, Sofran,
Not an issue towards the end. So the problem is, in trying to take a drug like that, if the person is going to be nauseated for 2 to 3 weeks, they can't take water, they can't take food, you're talking about automating a hospital visit because immediately they're going to get dehydrated, they're going to lose their strength. And what do? How do you take those drugs?
yeah, it's unfortunate, like, the side effects can cause a lot of things, but at the same time, there are other medications to offset those side effects. Maybe like, cutting those pills or powder form or a syrup form, you gotta play around with it. But it's end of the day, if the patient is having the symptoms, it's hard unless like, if they're put in the hospital, that's even worse because of the medication, right? So alternative drugs could probably, help that situation. Going, probably if they have been on some, let's say, donepezil 5 milligrams, right, you may want to up it up to 10 milligrams, something of the same class of drugs, but increase it a little bit. And I did that for some of my patients, like, and patients' family tells you that, if they go down or, the patient was good on this, can we go up on it? Even sometimes, 15 would be a lot, but sometimes it works for them,
The big question is how can you get a patient, forget the person I'm here, any patient, if a drug is going to induce nausea for up to 2 to 3 weeks and it's normal, how can that patient possibly take that drug unless they're on an IV and getting some sort of food intake?
Yeah, it's definitely hard, with those side effects. It's hard for the patients, and they can have a lot of things going on. We can't force it. That could lead to like aspiration and all that stuff, right? But again, maybe like cutting down, or maybe finding a different formulation. If there's one that can probably help. Maybe. Sorry. It could be. There could be something else going on. Maybe, like, she could be on some of the medications is interacting with the new drug too. That could happen. There's always like a drug-drug interaction. For example, diabetes medication can cause severe nausea and GI issues, right? Antidepressants can cause that too, right? So maybe cutting down on one thing. It's all about like trial and error sort of thing. What works the best. But you got to identify what other drugs can contribute to that. It may be causing nausea, but at the same time, antidepressant medications, if they are already on, could be a contributing factor too.
So I'm gonna give you a non-medical answer. So if your person is on, so I'm not a doctor or a nurse. Can you hear me? So I'm not a doctor or a nurse. See, you won't say on. Hello? That's right. So I'm not a doctor or a nurse, okay? So when we're caregivers, we always have to see what I mean. We always have to weigh the benefits versus the benefits, right? Because here's the thing we know, we have Alzheimer's dementia, there is no cure, right? So if she's taking medication and the side effect is worse than the benefit, this is something you to advocate to stop or try something else. So that's always what caregivers is battling. Okay, like, is the benefit of this drug, what I mean? Is the benefit of this drug worth the side effects? Quality of life. So when you start this process, one of your goals,
Again, like I said, quality of life, are we gonna add more medications if you know the diagnosis, right? Is that patient gonna take those medications? Or is it the side effects she has to deal with, right? A quality of life, support is more important, empathy, it's all about, again, it's case by case and family has to involve. Yeah, getting the diagnosis could be fine, at least for the family members, they can be proactive, knowing, oh, this runs in the family, right? So, getting the diagnosis, but when it comes to medication, it has to be family members and physicians, having the conversations, but definitely, 94 years old, if it was my family, I'd rather have my grandma to have a nice time, wherever she is, whatever she wants to do, maybe improve more, keep herself active with some games or maybe Sudoku or something, just to have that process going on. But again, I don't want, again, it has to be more personal and how much the family wants, the medications for that loved one.
One more question is we'll have Clifton to come up, and then I promise, that we're gonna have this fixed about the time next week. So we're gonna work hard, okay? And I promise time that we're gonna have it fixed. So here's Alzheimer's dementia question. So as I know, there is no history of Alzheimer's or dementia in my parents, but my mother has Alzheimer's and dementia. What can I do to help reduce the risk of Alzheimer's and dementia? So she did ask about supplements. So I want you to talk about how supplements don't work. Can you talk about that?
So it's a multifactorial effect, right? So if there's a family member or family history of Alzheimer's, right, you always want to make sure to minimize other risk factors, right? You want to have a good lifestyle modifications like eating healthy, sleeping on time, kind of thing, right? Risk factors like tobacco, alcohol, substance abuses, any of that stuff, right? Taking care of other chronic disease management like diabetes, hypertension, asthma, COPD, right? So that can, and also the other chronic disease management can also prevent you from stroke, right? Which could be another risk factor, right? For dementia or Alzheimer's, we call it vascular dementia if you had a history of stroke or traumatic brain injury, right? So you want to minimize those. Now, once you do that, having that, you can take supplements or eating healthy. And they say vitamins, I always recommend just regular vitamins, I'm not 50, but I still take Silver Central, one tablet. It comes in women's version too. The reason is you want to have those nutrients or the vitamins which are deficient. It may not happen in all the foods we eat, right? Eating healthy, they say omega-3 fatty acids, if you want to eat that, that's more in nuts, different kind of nuts. So anything which can enhance your brain activity, keeping yourself active, having that exercise routine, doing it religiously, healthy lifestyle would minimize a lot.
Okay, I think that's it, because I'm taking care of this one right here. So we're gonna have my friend Clinton to come up, because I said his name wrong. I can't say Dr. K, but he's gonna say a few things, and I'm gonna get your door prize tickets out, because you've been so good, I'm gonna give away a few door prize tickets, and then we're gonna take a break so we can get sound fixed.
Everybody, let's give Dr. K a great big hand for that. I almost feel like I was in church for a minute. But real quick, with Sage Health, like Dr. K said, we are committed to you being, commit this to memory, happy, healthy, and out of the hospital. That's what we're committed. That's what our doctors are committed to do. That's why you come see us more frequently. Something that I wanted to make sure that I highlighted was most physicians' offices have a panel of anywhere from 1,500 to 2,000 patients. That's a lot. And that's why most of the time when they go to the doctor, most doctors walk in the room with their hand on the doorknob. With us, our doctors, they are limited to only 400 patients per panel. That's why they get that 90-minute first visit, and every visit after that is about 30 to 45 minutes. So that, because not only is the doctor talking to you as the patient or the caregiver, we want to hear about what's going on with you. Dr. K and his staff, which they are amazing, they're not all about pushing medicine onto you as a patient. They want to make sure that there are no drug interactions. There's a lot of things that happen. Just one quick story. One of the tests that we run at the clinic is an EKG. One of the patients came in, had the EKG ran. They sent that EKG to our cardiologist. Our cardiologist said, this patient needs to go to the hospital stat. What happened was that patient actually had to have open heart surgery, and pretty much by having that EKG done, it saved their life that same day. That's the kind of care that our doctors are committed to as patients. So with that being said, we do a lot of things at Sage. Like Dr. K said, we do bingo, we do chair yoga, we do Zumba, they do line dancing classes, we have silver sneakers. There's an array of activities that you can come. And you don't have to be a patient to come and enjoy those activities. We'd love for you to be a patient, but you don't have to be a patient. We would love for you to, if you haven't already gone by, please go by and talk to my community outreach specialist in the back there. I have Miss Tamara Thomas back there and Miss Nakisha Barbie as well. Please go by there and talk to them. We will also have a great insurance agent back there. If you don't have a plan that we accept, you can speak with Ms. Gina Rouse. I know we have some other agents around the building as well. We'd love to get you connected, get you plugged in with who we are. We want to see, as many patients as we can at Sage Health. The thing is, with us being in Little Rock, North Little Rock, and Brian, our offices or clinics hold about 1,600 patients. That's what we're limited to right now. But the more patients we get, the more we can expand, because we believe that this is the future of healthcare, and this is the healthcare that you deserve. So, Carolyn and your staff, thank you so much for allowing us